listening to the Pharmacy Podcast Network.
LTC Pharmacy Podcast. Welcome, everyone, to the LTC Pharmacy Podcast. We're glad that you found your way here. With us today, we got a special guest host. Again, it's been here before. Before we get into that, we're talking about Beers criteria today. We're just going to delve straight in. It's an incredible criteria, but it's also one I can remember. Tamara and I were talking about this before we got on this. That from the time that I've started consulting in long-term care, Beers criteria was something that came up time and time again for potentially inappropriate medications. And I think it's such a crucial item to have in our toolkit to look for the appropriateness of meds in the elderly population. So with me, as always, is my wonderful and amazing co-host, Tamara, who together we drink enough coffee for 4 or 5 people so that we can stay awake and on here. But with us again, returning back from, I think the last time you were here, Dr. Simon, was deprescribing, I think was what we talked about then. And so kind of a fitting transition to Beers criteria today. But the S-Dog himself, Dr. Steinman, welcome back. And thank you for being on the show.
Great, thank you. This is the only place I'm called S-Dog, and glad to be named that way.
Well, good. I'm glad that you found a place with us. All right, so Beers criteria. One of the things that I think we see just all the time in long-term care are falls, and our precious elderly people that we're taking care of, and we're all trying to do the best we can for. They just, falls are a part of a lot of their lives, and it's a terrible thing. Obviously, if we can prevent some of those falls, that's what we want to try to do. And sometimes that's not an option. It could just be weakness or just themselves and disease state progression, things like that. But there are times where medications are impacting that person's life, and it's causing them to fall. And when we look at the Beers criteria itself, and I think table 3-ish, it talks about some different medication classes that can cause falls, like anticholinergics, antidepressants, epileptics, psychotropics, etc. But I think as consultant pharmacists, we look at their profile and we say, my goodness, they're on every single one of those drugs. So what in the world do we do? Where would we start? So I just want to pose this question to you. What's a great place to start? What's a great place to prioritize when we're talking about falls in the elderly population when it comes to medications?
Yeah, it's a great question. And as you can imagine, there's no, single clear answer. And the way I like to think of these drugs is that, a lot of the drugs that are on the Beers criteria that are specifically called out as increasing risk of falls. And there are many of them. There's anticholinergic, there's a bunch of antidepressants, there's antiepileptics, benzodiazepines, Z drugs, opioids, antipsychotics. So it's almost any sort of CNS active medication, not all of them, but many of them, do increase the risk of falls. And so, but none of them, it doesn't mean if you get the drug, of course, doesn't mean you automatically will fall. And if you don't get the drug, it doesn't mean you won't. So this is a risk factor in the way that a lot of other risk factors exist for falls. So the way I like to think about these drugs is just like I do for any other risk factor for disease. If I'm treating a patient with cardiovascular disease, can I decrease their risk factors for future MI or stroke by improving their lipids, by decreasing their smoking, and so forth. So the same thing with someone with falls, are there modifiable risk factors that I can engage where reducing that risk factor is going to cause more good than harm? So for a lot of these medications, it kind of always raises the question for me, if I have someone who's falling or I'm concerned might fall, if they're taking one of these drugs, it kind of raises that red flag in my head. Like, is there a way I can safely and effectively get this person off this drug? Is there a safer and a more effective alternative, which oftentimes would be a non-pharmacologic alternative? And sometimes the answer is yes. And then that gives me an impetus to try to go and do that thing. Sometimes the answer is no. Like a person's got really debilitating depression. They're benefited by an antidepressant. Many of the commonly used antidepressants all seem to increase fall risk. So it's not like there's only one culprit, there are many culprits. So, in that case, probably the better thing would be to keep the patient on the antidepressant and do the other things we do to try to reduce fall risk. So it's just important to recognize that just because a drug is on the Beers criteria doesn't mean it should never be used, but it just should raise that extra red flag about sort of thinking, can I reduce this drug safely and effectively because it does pose a especially high risk?
Yeah, I like that. And I think that's such an important thing for all healthcare providers to remember. I remember when I'm training new consultant pharmacists, I think you brought up a really good observation. A lot of times you show them the Beers criteria and they say, oh, well, they just can't be on any of these drugs. Well, no. There's times and there's places where they're going to have to be on those. And I like how you took a very, patient-centric approach to that, where you're looking at it and saying, this person may be able to reduce this, and this. And if we try and it fails, well, then they may need to stay on that medication. And there's obviously oftentimes safer alternatives, like you mentioned. We talked a little bit about depression and antidepressants. And yes, they almost all have a fall risk associated with them. What about depression, anxiety meds? Are there safer alternatives, some that seemingly in practice seem to not cause as many falls? And if so, which ones are those, or what are some recommendations you might have there?
Another great question. The challenge is, if you look at the Beers criteria, there's only 3 specific antidepressant types that are called out as increasing risk for falls. Those are SSRIs, the SNRIs like venlafaxine and duloxetine, and then tricyclic antidepressants. But it doesn't necessarily mean that all of the other antidepressants are necessarily safe. What it basically that does mean is that, we have good data on these 3 specific types of drugs that increase fall risk, but for the other drugs, there's not such good data, so we don't really know. And by no means is it guaranteed that other drugs, for example, mirtazapine or bupropion, is necessarily safer. And in fact, there's some evidence to suggest that they might not be. So I think the solution here is not necessarily to say, oh, as long as I just pick a drug, an antidepressant that's not on the Beers list, I'm fine. That's not necessarily the case, specifically around. That's true for some other conditions, but not in the case of antidepressants. So I don't feel like there's like a single antidepressant I can really point to and say, this is the safe one to give for people with falls. I just don't think we have that information. I think it really just depends on, I would still probably pick my choice of antidepressant on what I think is the most helpful to help their depression, because I don't feel like we have strong evidence to suggest that one is substantially safer than the other regarding falls. Of course, they have other side effects that might be differential between different antidepressants, some more anticholinergic than not. Some have, a variety of other side effects that, we clearly should take into account in making that decision. But I wouldn't say there's a huge evidence to suggest there's a major fall risk difference between them.
Great. Yeah, that's fantastic info. And I think you're right. I mean, when we're looking at that, obviously we want to control their depression. And if that is achieved by one med, then let's try some other tactics to try to reduce the falls, if at all possible, if they need that medication. Another huge area is pain. And I think we oftentimes, the older I get, the more I hurt. So I can only imagine if I fast forward to the 80s, what I'm going to feel like. And we obviously want the remaining years of our sweet patients' lives to be good ones and ones that are pain-free. But with pain meds often come side effects, drowsiness, dizziness, etc. And what would you recommend when we're looking at these residents that are on, Norco or oxycodone or whatever, and they're having histories of falls, or they're having routine recurrent falls? Yeah. What would you recommend in that scenario? Is it very similar to the other times where we just need to try to treat their pain and mitigate in other ways, or is there some safer alternatives, or what would you recommend there?
Yeah, I think that the same principles that we were just talking about regarding sort of antidepressants is largely analogous, so not entirely for pain medicines. Now, there clearly are some pain medicines which are safer for falls than drugs like antiepileptics or opioids, and those are the acetaminophen And NSAIDs, topical medicines, for example, topical capsaicin, or topical diclofenac, or topical sort of menthol. So these things have not really been associated with falls, and so they are safer. But of course, for a lot of people, acetaminophen alone might not be sufficient. And regarding opioids, there is another Beers criteria suggesting against using chronic use of opioids. It does not say to avoid short-term intermittent use. Short-term intermittent use, unless someone has another additional risk factor, is probably okay. But it's just like for chronic daily use, that's really where the Beers criteria says to try to avoid opioids because of the negative effects on kidneys, on sort of gastric symptoms and risk of GI bleeding, increasing blood pressure, et cetera. So in that case, it's sort of similar to the general principle of, are there other things we can do that would either be safer pharmacologic and non-pharmacologic strategies? We just talked about some of the safer pharmacologic strategies. So clearly, I will always try acetaminophen first, pretty much. And I'm thinking, are there any topicals that I can try? Topical lidocaine, topical capsaicin, these other things, which we know are safer. In a lot of regards, not just for falls, but for cognition, and other sort of CNS related side effects. And then beyond that, if it's sort of exhausted those possibilities, not exhausted, but concurrent with trying those possibilities, I really try as much as I can to try the non-pharmacologic space. Is there, physical therapy is my friend. Like, if I could be a physical therapist, I'd probably do a lot more for my patients than I am as a geriatrician. It's like, if I can get the patients to see the social worker and the physical therapist after I see them in clinic, like that's as a win as far as I'm concerned. So physical therapy, of course, can be incredibly helpful. For some people, acupuncture, massage, other non-pharmacologic therapies, doing things to improve their mood, of course, because there's a huge affective component to pain. All of these things, and for some people that's going to work well, and for some people it won't. And so some people are going to need some of these fall risk-inducing medications, and that's okay. But we should be thinking of them as, I wouldn't say a last resort, because we shouldn't be like stringing people along forever in severe pain, for years and years, and finally we'll give you, one of these drugs. We shouldn't be doing that, but at the same time, we should be, let's try these other things first. Can we get you on a safe and effective combination pharmacologic and non-pharmacologic medications that are going to help address the pain that you're having, and maybe not take it away entirely, but reduce it enough that you have a good quality of life and you're able to function in the ways that you do. The other thing about pain in general is, we should be targeting we should be targeting function as the outcome rather than pain as the outcome. So as long as people are able to do their daily activities, lives, and the pain is not disabling them or really interfering with their ability to do the things they want to do, that is really our goal, rather than making someone pain-free. Because to get someone truly pain-free, oftentimes you need to load on so many medicines that you cause more harm than good.
Right. Fantastic points. I mean, we've covered several areas that I think we see routinely in this population. When it comes to falls, Beers criteria, great resource. Are there any other resources that you would recommend that you've used in practice with patients that have frequent falls that might be something that you would recommend for us to take a look at too, if we're just kind of stuck and don't really know what maybe to do next?
Yeah, I don't have like a specific go-to site that I can think of offhand or a patient handout, for example, that I talk about falls. But the things that I really sort of think about are, what are sort of the non-pharmacologic strategies that I can do to address the multifactorial nature of falls? And so thinking like, first of all, what's contributing to the fall? Is it weakness? Is it impaired sensation? Is it lack of balance? Due to a neurological thing or an inner ear issue? Is it because they can't see? Is it because their environment is hazardous and they don't have grab bars and there's like throw rugs and things like that? So I really try to focus as much as I can on sort of understanding what are the potential things which are contributing to the fall, and then giving both the to a certain extent pharmacologic, but often mostly non-pharmacologic strategies. So again, like the best, if we want to talk about how I can really help patients, and, physical therapy, social work, and I'll add occupational therapy there as well, because like the best thing I often can do is like, get my patient to to PT and get them to see, is there a gait assistive device that's going to help them? Maybe they're using a walker, but maybe it's not the right walker for them, or maybe using a cane, they should be a walker. Maybe they're using a walker and they should be using a cane. Like, and the PT is much more equipped than I am to know what the best thing to do and to help the patient figure out to use it and know what's going to work with them. And then, of course, occupational therapy. Are there things that the patient can do to improve the home environment or the residential environment wherever they're living, in terms of grab bars, in terms of visual cues, in terms of better lighting. So it's all of these sort of multifactorial things. Maybe the issue is they're falling because they're getting up at the bed in the middle and they need to pee. And so maybe the solution is just giving if it's a man, like a bedside handheld urinal, they can just sit at the side of the bed and pee in, and then go back to bed. So it's like all these like little things that I really try to focus on before I think about, like, is there a drug that's gonna help with the falls? And then similarly, another thing I'll think about, are there drugs which are contributing to the falls that I can help to try to take away safely and not cause lots of problems because I suddenly withdrew a drug the patient was counting on to control their pain or whatever other thing that drug was being used for.
I think those are all. Oh, go ahead, Scott.
No, Tamara, you go.
I was going to say, I agree. Physical therapists should be like some of our best friends. My sister's a physical therapist, so I have an appreciation for them. But also, physical therapists can spot side effects really well, and oftentimes better than pharmacists or providers because they're with them more than we are. And so I enjoy collaborating with physical therapists, and I think that's a great point. And we can work together to time up medications with therapy and address side effects and those kind of things. So I'm glad you brought physical therapy up. But another contributor to falls that we haven't touched much about is those anticholinergics. And they are, they're in the 2023 AGS Beers criteria a few different times. Table 7 lists medications with high anticholinergic properties. There's the drug interaction of combining an anticholinergic with another anticholinergic. And of course, there is the recommendation to maybe avoid anticholinergics in patients with dementia, that they might be potentially inappropriate to contribute to cognitive decline. So I can't tell you how many admissions I have that come in on an anticholinergic medication, whether it's, amitriptyline or one of the muscle relaxers or a bladder medication that maybe they're taking. So when it comes to those anticholinergic medications, do you think it would be helpful for us pharmacists to proactively, leave notes for the provider saying, hey, this medication is highly anticholinergic, here's some less anticholinergic alternatives? Or do you kind of wait for, I hate to say it this way, but you kind of wait for the dry mouth and the cognitive decline to start before you start switching up those medications?
Yeah, great question. I try to be proactive about it because I don't want to wait for the person to fall or the person to have a serious adverse event or to end up in the emergency room because they have sort of fecal impaction and they just are in terrible GI distress. So I will definitely try to be proactive about that, but again, sort of titrate how proactive I am to my level of concern based on how anticholinergic the regimen is or the drug in question is, and then also like what is the underlying, protoplasm of the patient. Obviously, if there's a 50-year-old marathon runner, they can also have dry mouth and constipation, but I'm a little less concerned about them than a frail 90-year-old. So it's the same thing when thinking about my different patients, like what are their comorbidities, what's their overall functional status, their age, and therefore how aggressive I will be. But in general, because these are drugs that are oftentimes like, we have good substitutes for many of these drugs, both pharmacologic and non-pharmacologic. Most of the ones that you mentioned, like we have other drugs for neuropathic pain. We have other ways to help people sleep. The pharmacological ones aren't so great for the most part, but at least non-pharmacologic strategies. So there are easy things we can do to sort of switch people from these drugs, even if it's just going from a first or second generation antihistamine, if it's for seasonal allergies. That can often be really effective. So this is a class of drugs that I tend to be fairly aggressive in really trying to proactively reduce. But again, like with the approval of the patient, the last thing I want to do is like just take a drug away from a patient, make them feel abandoned, make them feel like I am, hurting them rather than helping them because I've taken away something they think is important and I'm not giving them anything to replace it. And why should they trust me if I do that? So making sure that, the patient is on board and having good communication, I think, is really essential to make sure that, both the changes are durable and that doing so improves the clinician-patient relationship and sets the stage for future positive things as opposed to irreparably damaging it.
Right.
Yeah, I agree. When I see my nursing home patients and when I see patients at the deprescribing clinic in my community, if they're on something like a Tylenol PM every night or, a tricyclic, and I just bring up like, I don't know if you know this, but this medication could contribute to cognitive decline over time. Oftentimes just talking to the patient about the risk, they're more than willing to switch to an alternative, especially if there is a good alternative instead of continuing when that, I think the risk of cognitive decline always is a red flag for people because no one wants to lose, their cognition and their brain power as they age. That's for sure.
Exactly. And sometimes these effects, are real, but they can be subtle. So like when you talk about, do you wait for someone to have the dry mouth? Well, someone might have like a little dry mouth. It's not enough that like it's screamingly obvious to them or to you, but it's enough that it's impacting their taste and, increasing their risk of, dental caries and things like that, or the same thing. Maybe there is some subtle effect in their cognition. It's not dramatic. They haven't noticed it. Their family hasn't noticed it, but they're a little less sharp than they might otherwise be. And so if we wait for like the adverse events to get clinically overt, we've sort of missed all the benefit we can get from addressing the more subtle stuff as well.
Yeah, I agree. I like to be aggressive too in getting patients off these medications before problems arise, and I'm glad you agree. Another class is those potentially inappropriate medications that we all kind of know about. But as we progress in healthcare, we think we're making progress, but then you still come across some of those orders where you kind of shake your head. And so I'm going to give you an example. My uncle called last week and he said, I was prescribed a new medication for my diabetes. And I said, oh, really? That's great. Because I knew his blood sugars had kind of been out of control. Mm-hmm. He said, yeah. And then he named, it was glyburide. And he goes, but my doctor said, only take it if my sugars are over 300. And then it'll drop it back down. And so we see these as geriatricians and geriatric pharmacists. We see these potentially inappropriate medications, but sometimes it feels like we're not making much of an impact. But how can us pharmacists, make an impact or be more effective in making recommendations to get patients off those potentially inappropriate medications?
Yeah, I mean, great question. And it's hard. I think that I maybe sort of answer that with two ways. The first thing is that, pointing people towards, if it's just like my word versus your word, like, why should you listen to me? But if I can point to like specific guideline or frame something in a non-threatening way when I'm trying to communicate with another clinician, oh, by the way, did you know that the new ADA guidelines or the new AGS guidelines or whoever, the new guidelines basically suggest that, and the Beers criteria suggests that this is probably the great choice. And let me suggest something else. And even better yet, like, let me offer to help switch your patient over to that drug if you have the authority and the relationship to do so. Sure. Take work off their plate rather than add work to it. So I think that's, one general strategy. And I think that, being respectful and helpful is of course necessary, but I think sometimes we get to the point where we are overly differential, like, oh, this person, I'm just a consultant and this person knows their patient better than I do. And that might be true to a certain extent, but if they're doing something that is kind of obviously bad or probably bad, like, we can have a role. It's okay to like speak up and respectfully say like, actually, there's probably a better way of doing this. And let me help. Let me proactively be supportive and respectful and helpful. The other thing is that it can be discouraging because like you make a recommendation and the doctor basically gives you the middle finger, right? It's just like, no, I'm not going to do that. They either do it overtly or they just don't make the recommendation and you feel like, and then, it can be like, why am I wasting my time making these recommendations and no one's acting on them? But, the way I like to think about this is like in the face of that frustration is like, think of all the drugs we give to prevent bad things, like aspirin to prevent future MIs. And if we think of it from like a number needed to treat phenomena, it's not like everyone would give aspirin, suddenly they won't have an MI and they would have had an MI. No, it's like a number to treat of 30 or 50. So if we can think like, if I'm going to make like recommendations for 5 patients and one of those 5 patients makes the change, that's a win. we might focus on the other 4 or 5 patients and be frustrated, but like if we expect 100% success, like there's nothing that's 100% success. You know, so reframing our definition of what success means, I think, can be helpful for getting through those frustrating times about when it just feels like people aren't paying attention to all the wisdom you're trying to impart to them and help their patients and your patients.
Yeah, that's good advice, because we always, of course, think of the one negative instead of the many things we do to help our patients. We just remember that one thing that didn't quite go our way. So I think that's great advice. So when it comes to the 2023 AGS Beers criteria, what's your personal favorite update?
I would say like my personal favorite criterion is actually, it's a criterion that was there before, but I still really like it. And that's basically to avoid 3 or more CNS active medications when you can. And the reason I really like that is it's maybe less explicit than some of the other criteria. It's like, and it makes a point that a lot of the times the problems they have is not because like one single drug. And if I got that one single drug off the regimen, suddenly everything is going to be great. But it's more like if we think about the regimen as sort of in its totality and sort of the cumulative burden of these different medications and how they interact. And so if we just start loading a lot of CNS active medications on people, like it's just, some people need it, but for a lot of people, they don't need it. And it just causes falls, cognitive decline, causes balance issues, causes all sorts of negative stuff. And for me, that criteria, I'm trying to avoid 3 or more CNS active medications, and 2 or more, if you can get it down to as few as possible. It's just a stark reminder about sort of that, we're playing the long game here, not just one drug at a time, although that is important, but like, can we think about sort of how we're changing, the totality of the regimen and how that can sort of, those changes can add up in a beneficial way over time. In terms of the new stuff, the biggest changes to the 2023 criteria compared to what was before is the elevation of rivaroxaban from the previous place listed, which was used with caution, to now it is avoid. And then previously warfarin was not on the criteria, and now it is on the criteria. These are controversial, especially the rivaroxaban one. We've definitely heard from a number of people who have expressed some concern about that criterion, and we can talk for hours about that. But I think the short story is that, it doesn't mean that no one should use rivaroxaban. It doesn't mean that no one should use warfarin. There's a valid therapeutic role for both of those drugs. But we know from data that compared to alternatives, these often are inferior choices in terms of safety outcomes that are important to patients. And we have some, good evidence to suggest that that's the case. So again, it serves as a reminder, not as a must be this way 100% of the time, but that for many patients, maybe they're not great choices, and we can do better.
Yeah, I think people have paid attention to it as well, because in the dispensing side of things, I have been dispensed a lot less rivaroxaban in the long-term care space than I used to since the 2023 update came out. So people are paying attention to that, or I don't know if there's a correlation there, but it sure seems like since the 2023 update came out, there's a lot less dispensing on my end in the long-term care space of the rivaroxaban.
Interesting.
Yes. So Scott and I made a little friendly wager before this podcast. We have one last question for you. Sure. And the loser between Scott and I has to do 30 burpees. So I hope your answer is what I predict.
I'm hoping that it's going in my favor on this one, but sure. Go ahead and ask.
All right. So as you know, burnout in healthcare is on the rise. We have people leaving our profession, and we have an aging population, and not enough geriatricians and pharmacists to keep up. And so in order to prevent burnout with everything you have going on with the Beers criteria and the USD Prescribing Research Network and your thriving practice, what form of exercise or meditation, or what do you do yourself to prevent burnout?
What do I do, or what do I wish I did more?
Either.
If it's wish you did more and it benefits me, that's fantastic. That's
I do have a clear answer to that, and that's
okay.
running. So, and I was actually training for a marathon over the winter, like late fall and winter, and then I just injured myself just sprained a muscle, nothing too bad, but it took me out for about 4 weeks. And I noticed a marked decline in my mental well-being during the time. That wasn't terrible, but like, I just like, I was like, oh, this running thing is really good for my mood. Like, and so it was a good natural experiment. Who knows if it was causal or there were other confounding factors, but for me, I've found that exercise, in particular running, is helpful. So it's a good reminder to myself, even those days when I'm just tired, I don't feel like it, to try to get out there and force myself to do it.
Well, that's an excellent
Easier
answer.
said
I
than
feel
done.
like
Yes.
I won
Yes.
because, well, you can decide. Scott said biking and I said hiking, but I think
I
hiking
think
is
hiking
closer to running.
It's
so I
closer.
feel like, Scott, you got the burpees.
I think you both got to do 30.
Man.
Well, I was going to say, I mean, I don't know that this is going to help my burnout doing 30 burpees, but
I don't know. At least like you both, or you put it from 0 because they both exercise. I thought you were going to what are you going to say, like karaoke or cooking or sewing or something. So.
I know, that's
said,
true. That's true.
I told Scott, I hope Dr. Steinman surprises us and says like skateboarding or surfing or something.
Yeah, just something just crazy.
Yeah.
Well, as always, Dr. Steinman, I've got tons of notes from you being here. I think everybody listening is probably taking a lot of notes too. We always appreciate having you on the show. You do a fantastic job kind of bringing this down to earth, looking at these different criteria, guidelines, everything else, and how does this work in the real world with people. And I always love how patient-centric and your centered approach to patient care is, because I think that's what's lacking a lot of times, unfortunately, in our society today. So thank you for all the thoughts on that. And I can't wait to have you back on again. We'll have to figure out another topic for you, but thanks again so much for being here.
Hey, thanks for having me. Enjoyed it.